Thank you, Theo. Can everyone hear me?
Yes, we can hear you very well. Okay.
I've been given the task of just reviewing clinical guidelines in relation to multimorbidity and complexity. Just briefly, I started my medical career in the latter half of the 20th century, and at that point, there was the first great revolution of medicine in terms of understanding pathology, pharmacology. And then through my career, I've observed the second great revolution, which is the development of clinical guidelines, which have overcome a number of assumptions. So for instance, when I was a medical student, it was suggested that the best way to look after someone with hypertension who was elderly was to take their age and add 100 millimeters of mercury, and that could be a target blood pressure. That turned out to be a poor strategy. And so we've enjoyed over the last 40 years one of the great revolutions in medicine, which is the development of clinical guidelines around specific conditions, really independent of patients' age and other factors. The strength of this process also is part of its weakness, in that all of these studies have really concentrated on single diseases and interventions in patients which have been selected for the power of a clinical trial and to avoid the risk of bias in terms of results. And so the patients who participated on the whole in these trials have had substantial physiological homeostasis and substantial physiological resilience, and have often been selected to avoid those with comorbidities and multiple medical prescriptions. And even in those trials which have been done, those who were entered into the trial who did have a comorbidity and other medications, the results of these dimensions often weren't included in the analysis of the endpoints. The result of our guideline journey, in fact, with regard to multimorbidity, the National Institute of Clinical Excellence has produced a guideline around multimorbidity and clinical management, really at about the start of our project, of the C3 project, in September 2016. But actually, if you dive into that in detail, and it is a large and very comprehensive document, it's really a summary of principles. There really isn't any elements in there which would allow decision making that aren't fundamentally the principles of good medical practice. And it's a good summary of the size of the challenge facing us. So in terms of reconciling guidelines, the project looked at 4 common comorbidities, and we went through a complicated process of deriving a single set of guidelines. And even taking 4 common systems, that led to almost 500 decision rules. However, actually the challenge facing us are the patients who don't have single diseases and who don't have homeostatic resilience. And this challenges frailty and complexity, and that's the challenge that I face as an active clinician. And the issue with frailty is it's almost never the result of a single pathology or the failure of a single organ system. And often, because the patient doesn't have physiological reserve and is frail, the clinical endpoint would be very different to that in a single disease trial. And it's a clinical compromise between addressing what is quite limited reversibility and avoiding treatment-associated morbidity, as has been discussed in the first talk. So, the C3 coordinated care plan really allows the decisions of multiple caregivers to be shared with the patient. It also allows us to document and summarize where we've deviated from a single disease guideline and why we think that that is in the patient's best interests. And then going forward, the C3 platform would allow the systematic collection of such data, which then could allow us to develop tools which would allow us to make better decisions within this much more complex dimension of multimorbidity and frailty. And that in the future, I'm sure will be supported by AI. But the issue of the C3 also is that it brings together a forward-facing care plan. One issue we have with electronic patient records is that they are comprehensive and complete, and therefore extraordinarily granular. And finding relevant information can be quite a challenge. For instance, a single episode as an inpatient can lead to 60 or 70 pages of documentation. So having a place that's visible across the whole care community and shared with the patient, where these decisions can be registered and the polypharmacy cannot creep back in when they see other carers is a very important component or an advantage of this system. I'd now like to just briefly talk about a second group of cohort of patients. And these are patients which I'm going to describe as having complex disease. And these would be patients such as a patient with rheumatoid arthritis who might have interstitial lung disease. They may have type 2 diabetes. They may also have hypertension. Any autoimmune inflammatory disorder increases your risk of hypertension, increases your risk of vascular disease through the autoimmune mechanism, and also through the commonly prescribed medications. And even the more modern biologic medications, such as Prevlast, can increase your risk of depression. Some of the biologic agents can alter your cholesterol. Typically, in addition, some of the very complicated medicines, say a biologic agent given to a CTLA4 blocker given to, say, someone with melanoma, many of these medications aren't really familiar to the community teams. And so having a place where there's information and support clearly visible is an enormous advantage. And so again, the C3 Care platform allows these common care plans to be created, which supports and reconciles these multiple care inputs. And also again, builds a repository of structured data, which allow tuning of guidelines going forward. I mean, it may well be that if you have rheumatoid arthritis, we should be targeting your hypertension as aggressively as someone with diabetes and hypertension. And I suspect that to be the case, but gathering the data for that is extremely difficult. And the C3 platform would be an ideal mechanism of doing that in a structured, easily accessible way. I think the final thing I'd like to say is that at the heart of the C3 coordinated care platform is that the patient has direct involvement and is an equal negotiator in the decision making. And I think all of the future care guidelines that we need to develop need to have patient input at their heart. And clearly this has to be driven by an effective communication system, which again the C3 platform delivers and allows the breaking down of the silos, which often are an issue in modern medical practice. So I know we're tight for time and we want to have some discussion at the end. So I felt that a shorter, punchier talk was the right approach. And so thank you. There's discussion going to be at the end. And I think I'll now hand over to George, who's going to talk about drug-drug interactions and the C3 solution. Thank you for your attention.
Thank you, Chris, for your presentation.